ovarian reserve and whether DHEA supplementation will be useful or not. So what is the ovarian reserve? A woman's reproductive potential with respect to ovarian follicular number and oocyte quality. There is a total reserve with regard to the non-growing follicles and the growing follicles. Basically, we are assessing this so-called ovarian reserve, and total ovarian reserve decreases with time following the continuous follicular recruitment. As you know, as the age advances, the number of follicles decreases, and the number of poor quality oocytes increases with age and reaches a maximum in the perimenopausal period. Even though there are so many millions of follicles stored in the ovaries, only nearly 400 ovulate during the time, and the decrease in the follicular reserve or ovarian reserve is not due to the follicular recruitment, but it is due to the natural death of oocytes by apoptosis. Almost 99% oocytes die by apoptosis by near the age of menopause. So decreased ovarian reserve means if the follicle pool at any given age is smaller than expected, that is the decreased ovarian reserve. In 2009, diminished ovarian reserve was the second most common diagnosis among infertility, and it's one of the least well-characterized etiologies of infertility, and it can also be encountered in young women. And there are a whole lot of factors affecting this situation due to increased age, lifestyle habits like smoking, pelvic infection, endometriosis with ovarian involvement, and family history of early menopause, and family history of autoimmune disorders, ovarian radiation, and ovarian surgery. And ovarian surgery is the one which we have to stress, because there are all lot of laparoscopic surgeries, especially the ovarian drillings, unnecessarily being done for the infertile patients, and that can decrease their ovarian reserve in the future. All the women, they born with finite number of eggs, and these reserve deplete with advancing age. Then there are poor quality oocytes, and this aging oocytes is the major cause of infertility in this population. And it can not only result in diminished response, even if the pregnancy achieves, it may result in chromosomal abnormalities, increased rate of aneuploidy in the embryos, decreased implantation rates, and increased rates of spontaneous abortion. So how to assess? As the first speaker has mentioned, anti-Mullerian hormone has been proved beyond doubt that it is one of the best indicator, and antral follicular count is one of the most important clinical indicator. And the advantage with AMH is it can be measured on any day of the cycle without much variation in between the cycles, and less than 2.2 is considered as the low fertility. Whereas antral follicular count, diminished ovarian reserve is considered as when there is cumulative number in both sides when it is less than 6. And it's never too early to assess the ovarian reserve. Even young women can be affected with decreased ovarian reserve. Also for both age distribution of menopause and the age distribution of natural fertility loss, a clear skewness towards younger age is present, suggesting that early reproductive aging indeed is relatively very common. So what is the right age, whether it is biological or chronological age? So there are a lot of data which suggest the biological age is the most important criteria, and study group outcomes, significantly low oocytes, lesser number of embryos, and lesser cryopreservation cycles when there is early ovarian aging. So ovarian age-based stimulation of young women with diminished ovarian reserve results in excellent pregnancy rates with in vitro fertilization. Age per se can be poor determinant of female fertility, since there is wide range in the relationship between ovarian reserve and age. So what is a poor responder? The SJK criteria is advanced maternal age, previous poor ovarian response, and abnormal ovarian reserve tests. In general, we all consider it as failure to respond adequately to standard protocols and to recruit adequate follicles is called poor ovarian response. So it varies between 9 to 24%, and successful pregnancy rate in these patients is as low as 2 to 4%. There will be decreased oocyte recovery, cycle cancellations, and significantly diminished probability of pregnancy. So there are elderly patients with abnormal endocrinological profile, young patient with abnormal endocrinological profile like hypothyroidism or hyperprolactinemia. But the main group is young patients with normal basal hormonal profile. These are the patients where we find it very difficult. So it can be diminished ovarian reserve, it can be due to genetic causes, can be due to infections, smoking, additions, and endometriosis. So premature ovarian failure need not be discussed, it's altogether a different situation. And concluding the points of poor ovarian reserve, there is growing proportion of women delay childbearing to their 30s. Lack of awareness of age as a risk for infertility, and fertility decreases with age. The pool of oocytes is fixed and decreased progressively during growth and development. With age, poorer quality oocytes are produced, increasing incidence of early ovarian aging has been seen in many patients nowadays. These are the challenges which we face. Older ovaries have few antral follicles, high rate of atresia, and increased resistance to stimulation. Despite various predictive tests, poorer responder reveal definitively only during ovarian stimulation. Need for a drug adds in the preliminary stages of follicle development and can avoid the first cycle failure itself, because all IVF cycles are very costly. So these are the gaps in the stimulation protocols. So we always start with either in the antagonist protocol or agonist protocol, we start with many of the gonadotropins, then give HCG and on. So all this FSH, all these stimulations adds on the primary follicles and the pre-antral follicles, and then it matures. So whereas if we add androgen, it can prime these primary follicles to a mature ones and quality ones, and it can improve the outcomes. But androgen use is a time consuming and the effect is not immediate. So the role of androgen in follicular maturation is mainly in the differentiation between the pre-antral to early antral follicles. And on these follicles, pre-antral follicles mainly, these receptors are present and it synergizes the effect of FSH. So the administration of DHEA has a role at this point. And the natural androgens, it reduces with advancing female age, and it starts declining from the age of 29 to 30. See, and the role of androgen in this follicular maturation, there is high concentration of androgen receptors in the pre-antral and antral stage. And it stimulates granulosa cells, and it has a role in follicular maturation and steroidogenesis. So as the age advances, there is decreased androgen levels, deterioration of ovarian environment, and resulting in poor quality oocytes. DHEA interferes at this stage. It supplements the decreased androgen levels. It adds IGF-1 on Graafian follicles also, granulosa cells, and improves the ovarian environment by stimulating mitosis, increases steroid production by granulosa and theca cells. All this results in the better quality oocytes. So this is an arising concept by treating the ovarian environment, where ovarian environment naturally deteriorates with age. DHEA is supposed to improve ovarian environment and resulting in decreased aneuploidy, improved embryo quality, pregnancy chances also improve. So decrease in aneuploidy also increases the clinical pregnancy rate and the take-home baby rate. And it's a steroid hormone secreted by adrenal glands, testes and ovaries, most abundant circulating steroid in humans, and can be converted to other hormones like estrogen and testosterone, and it decreases with age. The common actions are it acts as a prohormone, improves the steroid, ovarian steroid genesis and follicle maturation, and improves ovarian reserve. And patients demonstrated a steady increase in AMH over time and 60% improvement, and it is statistically significant in that quoted study. And DHEA increases the pool of follicles up to pre-antral stage, causing a steady improvement in AMH. It may positively affect recruitment from dormant primordial follicular pool, improves the ovarian environment, better follicle maturation, better oocyte quality, augments IGF-1 concentration, increased production of IGF-1 resulting in better maturation and from the granulosa cells. And effect on apoptosis, that's a primary process of elimination for originally recruited follicles. It may reduce apoptosis. So it can act as a prohormone, improves the ovarian reserve, improves ovarian environment, augments IGF-1 and reduces apoptosis. And it's a mild androgen, no side effects, especially if the dose is less than 100 milligram per day, safer than other androgens like testosterone and androstenedione, and known to which can negatively affect oocyte development. And we should take precautions while giving in patients who are prone to seizures, and should be avoided during pregnancy and lactation, and contraindicated in patients with malignancies. And the first results of DHEA administration started coming in early 2000, and this is one of the first published studies to propose that DHEA administration to poor responders would augment the gonadotropin effect. 5 patients had poor response to previous gonadotropin stimulation, and cycle before DHEA administration was served as a control cycle, and the dosage was 80 milligram per day. And all 5 women showed increased responsiveness to gonadotropins. Increased peak estrogen concentration was seen, and number of mature follicles increase also was more in these cycles, in these patients. And 1 patient conceived, cycle number 6, and delivered twins. Supplemental DHEA treatment during ovarian stimulation may represent a novel way to maximize ovarian response. IVF outcome before and after DHEA supplementation in a study in 2006. The aim of the study was to compare IVF treatment outcomes between pre and post-treatment cycle among a cohort of women with non-diminished ovarian reserve using supplementation with DHEA. 25 women with DOR, most of them were previous IVF failures. DHEA treatment started 4 months before the index IVF and continued. That was, the dosage was 25 milligram thrice daily. Patient underwent pre-DHEA IVF cycle and post-DHEA IVF cycle in the same sitting. And there were statistically significant difference in the fertilized oocytes and day 3 embryo blastomeres and cumulative embryo score per oocyte retrieved and the normal day 3 embryos. Findings of the study were higher number of oocytes, higher fertilization rates, higher average day 3 blastomere counts, less cycle cancellation rate, and well tolerated with no patient dropout. This study confirms that DHEA treatment increases oocyte and embryo numbers. Thus, DHEA may be beneficially affect or improves oocyte and embryo quality. Another study in 2007, which was a retrospective analysis to test hypothesis that DHEA supplementation might increase pregnancy rates and the outcome. And the cycle cancellation, positive HCG, implantation rate, clinical pregnancy rate, and miscarriage rate were analyzed. And the clinical pregnancy rate was much better. In conclusion, this resulted in significantly higher cumulative pregnancy rate following the transfers. And another advantage is with decrease in miscarriage rates. That was a retrospective analysis again, compares miscarriage rate after DHEA supplementation with control population. And the odds ratio was 0.49, and it was significant. And at a different age group also was compared in the same study. DHEA supplementation reduced the risk of miscarriage by 50% with pronounced effect on females who were more than 35 years, and miscarriage rates were comparable to rates reported in normally fertile populations. Increased in euploid embryos. To determine whether DHEA supplementation in women with POA increases the risk, increases the number of euploid embryos. And PGD done in 27 consecutive IVF cycles in women with POA. And ovulation induction was microdose GnRH agonist protocol. And there were significantly higher percentage of IVF cycles reaching ET of at least 1 euploid embryo following the PGD. And patients and decrease in aneuploidy was measured in another study in 2010. 22 patients were studied and 44 patients were used as controlled. Patient received GnRH agonist and gonadotropins. And there were significant less percentage in DHEA group with regard to the aneuploid embryos. And this was the first randomized study assessing which measured the live birth rates also. And the uniqueness of the study was, it was the first randomized study. And the live birth rate in the study group, OR fertilization rate, ET remained same in both groups. DHEA supplementation showed a beneficial effect on the live birth rate. And this drug should be considered for poor responder patients due to its simplicity of use and lack of side effects. Another study in 2009 that also resulted in higher number of follicles of more than 17 millimeter, total recruit oocytes and the transferred embryos also were more. And cycle cancellation was low, higher clinical pregnancy per embryo transfer and higher implantation rate. Current study shows that DHEA supplementation in poor responders undergoing GnRH antagonist IVF or XCET protocols augments ovarian response and enhances the IVF success rate. And this is in premature ovarian failure that also has been attempted. It's supposed to be effective first treatment in premature ovarian failure, but the data are not very adequate. And these are the latest studies, and the results in that also, DHEA supplementation in diminished ovarian reserve. The results were showing the best available evidence suggests that DHEA improves ovarian function, increases pregnancy chances, and by reducing aneuploidy, lower miscarriage rates. It over time also appears to objectively improve ovarian reserve. Another recent study that also shows that is also in favor of DHEA. There were significant difference in day 3 FSH, estradiol, antral follicular count, AMH, and inhibin B levels before and after DHEA supplementation in all patients. And it positively affects spontaneous pregnancies in women with the diminished ovarian function. That also is another study. And to conclude from all these studies, it can be resulting in higher number of oocytes retrieved. Hence, if we can do more transfers as well, and higher fertilization rates, higher average day 3 blastomia counts, more euploid embryos, less cycle cancellation rate, better clinical pregnancy rate, and it's well tolerated with no patient dropouts in most of the studies. And personally, I don't have much experience in using DHEA because we don't waste much time for these patients in doing IVF. But I work in a setup where we can't do any of the donor programs. So if I can convert one patient from the donor recruitment, it's worth trying these products. That's what I feel after preparing for this presentation. Thank you.
Thank you, Dr. Kunjumoideen. That was a great presentation and really elucidated the basic science behind the thinking that led to DHEA being introduced. The truth of the matter is, clinically, a lot of our basic science doesn't really translate. The logic doesn't translate into clinical practice. And that's the case with DHEA, to be honest with you. And I have used DHEA, and I have personal experience using it, and I've been very disappointed. And in the last, of the many studies you showed, and of course Glacier's papers are always there, but in a sense I feel like they're biased because that's his. But Weiser's paper is probably one of the best ones that he showed, but including Weiser and all the other papers, the meta-analysis does not pan out. And that's the problem. See, all these papers are showing patients with small small number of patients in the arms. And that's the problem with these studies, is that when you don't have adequate numbers, then you don't have clinical significance. You can say statistics is statistics, you can always prove it. But when you accrue the numbers and you look at it meta-analysis, you have less of a powerful effect coming through. And that's true with DHEA. On the other hand, testosterone seems to hold promise. Even the latest meta-analysis prove a potential significance, okay? So my feeling is DHEA is weak. The theory probably is correct, but DHEA is just such a weak androgen that it is not able to hold the promise in, absolutely. So I think testosterone and androgen use is probably going to show promise. And that is what I was preparing. I mean, at least the papers that I reviewed show that androgen has possibly a positive effect, but DHEA does not. So at this point, I personally would not use DHEA. It just gives false hope to the patients. But on the other hand, it is a cheap drug, as you pointed out. It's cheap. It is relatively safe because it doesn't do much. So, it's a very weak androgen. That's, the best effect is if you give it for at least 3 months ahead of time. And that's the thing. So patients are losing time as you're giving them for 3 months. If you look at the papers, some of the significant ones, they've used for 3 months before they actually start the IVF stimulation. So you need to spend some time using the androgen as well.